In this section, I'm going to talk about a topic which has become much discussed in recent years, and that is the role of ICTs in the self-management of illness. Self-management has come to the fore, I think, primarily because we've become aware of the ever-increasing costs of health services. Over past decades, medical advances have provided very exciting new opportunities for extending life, particularly by managing serious illness in later years. But the emphasis here is on management. They've generally not cured many conditions, heart conditions, diabetes, cancers, but they have enabled people to live longer with those conditions. But that involves managing those illnesses over a long period of time, and that is very expensive. Technological breakthroughs have led to wonderful possibilities for extending life, but at an ever-increasing cost. And there are increasing doubts, even in some of the richest countries, take the US and the UK for example, as to how those costs will be met. In the UK, as I mentioned in the previous session, about 85% of expenditure from the National Health Service goes on the cost of treating disease in older people often with more than one chronic illness. So it's become an attractive possibility that maybe the sufferers themselves, the patients, can acquire knowledge, support and equipment which will allow them to take over much of their own treatment. Why would that be useful? Well, it could be beneficial in health terms because they may know a lot more about their own condition than would the average patient, and therefore they can, for example, change their behavior. They can arrange their lives in such a way as to mitigate the impacts of their illness, and they can acquire knowledge, for example, about how better to seek care, who to approach, how to get information, how to seek help. But it should also reduce the cost of care by limiting the extent to which expensive professionals have to become involved in long-term health care. This approach depends to a large extent on the concept of reverse information asymmetry. What's the idea here? Well, it's a commonplace assumption that in dealings between patients and providers, the patients are at a disadvantage because their knowledge of what's going on with their own bodies is fairly limited. And therefore whatever the provider suggests is taken by the patient as being the correct solution to their problems. Even if the provider is, if you like, loading them up with tonics and placebos in order to extract money from them, the patient may have very little idea that that's what's happening and therefore will gratefully hand over the money. So it's always been assumed in health economics that there is this information asymmetry in which the patient is at a disadvantage. However, if you live with a serious illness for many years or even many decades, for example in the case of a chronic illness such as diabetes, you can become very knowledgeable about that specific condition. You know how you feel, you know how you respond to certain life events, you know how you respond to certain foodstuffs, to exercise and so on. You also have a lot of knowledge about the implications for yourself. What does this mean for your employment, for your lifestyle activities? And also, what does it mean for your family? Is the family going to suffer because of your illness? To what extent is the family going to have to support you and your illness? And what does this imply, for example, for education, nutrition, and so on and so forth? And the idea here is essentially that even if you have access to good quality care, you probably only see a provider for a few hours each year. So you may have contact with a perfectly good general practitioner, but you would only see them for 10-15 minutes at a time, and they will have very limited knowledge of what's going on in your life and how your illness is progressing, apart from the purely medical information that's fed back to them through tests and so on. And so a few years ago, von Ullmann and colleagues produced a paper suggesting that a much more practical way of approaching chronic illness was to see care as being very much patient-centered, with the patient, if you like, commissioning services sometimes commissioning in terms of payment, sometimes because they could ask friends for services, sometimes because NGOs and other groups would offer services for free. But this would be the patient driving their own care, or in some cases the carer of the patient driving the process. So here you can see various links to the medical profession, pharmacists, primary care providers, consultants, medical specialists, but also links to family members, informal caregivers, peer groups, people they know, and also something we've heard quite a lot about in recent years, the expert patient, somebody who's suffering from the condition or has suffered from the condition and has been given expert knowledge about that condition and the most appropriate way to treat it, the appropriate way to live with the condition, if you like, and somebody who is willing to pass on that information to other sufferers. For this session, it's important to look at the top right-hand corner of this diagram, because on the left-hand side, of course, all of these interactions with the health service, with peer groups, with expert patients could be done by mobile phone or email or some other electronic communications need. On the top right-hand corner, the changes over recent years have come by way of gadgets to, for example, test blood sugar level, the glucometer up in the top right-hand corner there, and to remote testing, collecting information, for example, on heart rate, on lung capacity, via devices which can be attached to a mobile phone. So ICTs have come in two ways, primarily through mobile phone links, but also through various gadgets which can move, if you like, the surgery to the patient's home, so the patient can become involved in their own monitoring and testing. What's new about this patient-centered care has in fact been going on for a long time, and on the website of the main UK diabetes charity, they suggest that diabetics in fact manage 95% of their healthcare, most seeing providers for a few hours per year. Obviously these people do play a lead role in looking after themselves, and that's not only about lifestyle changes, not about changing their behaviour, eating patterns and exercise and so on, but they will also carry out insulin injection, or a family member will carry out the insulin injection, and they'll undertake routine self-monitoring of blood glucose levels using equipment that's been provided by their doctor. Major changes in recent years is first that there's an awful lot of information available to the patient, easier access to medical knowledge, and a lot of that knowledge has been, as I've called it here, demystified, designed for general population, not for specialists. So understandable medical knowledge that they can use to interpret what's going on in their bodies and to make decisions about what's the most appropriate course of treatment to relate to that condition. And then there's a large range of reliable, user-friendly, relatively expensive medical equipment which can be used in the patient's own home, and then either the patient can act on the information provided by that equipment, or they can send the results of the readings on that equipment to the doctor, who can advise them what to happen. So it's a shift in the balance of where care takes place and who takes decisions. So while there is nothing new about the idea of self-management, there are hopes that developments in ICT may make the task easier or more effective. And it may also provide patients with an improved negotiating position to seek the best care, to reduce the traditional information asymmetry that we associate with health care. If we think first about the idea that people can join together with their peers in order to manage specific conditions, what's happened in recent times is that the potential range of people that you might join up with has expanded enormously, because communication allows you to link to many more people than in the past. So if we assume we're in a rich country context where you can have ready access to the internet, then there are a very wide range of groups to which you can appeal for support. So a very wide range of what we generally call patient forums, where people can discuss either a specific condition. AIDS was probably the forerunner here, but also cancer, heart disease, lung conditions and so on, or more general discussions about where best to seek advice, which providers to avoid, where the most expensive facilities are, where the most reasonably priced facilities are, and so on. A lot of these sites will be associated with NGOs and advocacy groups, and it's sometimes very difficult to distinguish between a patient forum and an advocacy group. Main difference here, I suppose, is that the advocacy group will have a specific brief to seek for better resources for specific illnesses. So again, HIV/AIDS was a forerunner here, with advocacy groups based on the internet demanding from governments that they provide drugs that were available, more resources to fund the supply of those drugs, free treatment for certain types of vulnerable people, and so on. I've been wandering through Facebook recently, and obviously since Facebook covers a very large proportion of the world, you can find Facebook sites covering almost every kind of illness where people discuss what sort of treatment they have, how it works out, lots and lots of alternative remedies for different kinds of conditions, and so on. So it's all there. People can talk about their condition on Facebook. It's become very common in recent times for these patient forums, which we, I suppose, start out thinking of as groups of people with similar interests, to be hosted on commercial websites. MedHelp, for example, is one that I've listed in the notes, which essentially allows patient forums to be held on their website, allows commercial firms to put up advertisements, which you don't have to go to if you don't want to, but will probably be linked to the particular topic of that forum. So they two things sitting side by side, if you like, with rather like a Google search engine, in fact, where the ads pop up. You don't have to go there if you don't want to. I've been fascinated by one particular site, which is called Patients Like Me. What has particularly fascinated me is the fact that this is presented as a social enterprise site, set up for very benevolent reasons. In fact, one of the people who set it up was suffering from a particular condition, and they thought a site like this would be very useful for people with chronic illnesses. To give an example, two of the statements on their site is that we take the information patients like you share about your experience with the disease and sell it to our partners, i.e. companies that are developing or selling products to patients. And then again, every partnership we develop must bring us closer to aligning patient and industry interests. That's a very interesting statement, and some would find it rather controversial, the assumption that it is possible to align patient and industry interests in every case. It indicates, I think, that a lot of these sites start out with very good intentions, but then drift into rather grey areas when it comes to negotiating with commercial organizations, because in the health sector there is no one solution, if you like, to particular problems, and people can tip the balance of discussion towards solutions to problems that favour their own interests. And certainly commercial organizations are rather adept at doing that. And indeed there are lots of patient forums on private company sites. And one interesting paper from Italy looked at 157 patient and health consumer groups, and 46 of those named at least one pharmaceutical company as providing funds, but only 3 of those were willing to divulge the amount of funding provided. So one becomes a little bit concerned about when a patient forum becomes an industry forum for promoting the sale of a particular commodity in the market, using patient forums as one means of promoting their own commercial interests. This is one area in which ICTs can make a big difference, that is in linking together people with similar kinds of concerns. The other big area is in the area of gadgets, if you like, devices which enable you to monitor your condition and allow you to decide when to take action, or provide information to your doctor and allow them to decide when to take action. Here's one recent one, for example. This is the MobiliCare kit, which was produced in Brazil, and it includes instruments to measure blood glucose, blood pressure, oxygen saturation and lung function, a heart monitor, pedometer, and a medical scale. And the chronically ill patients are given a little kit to take home with them, and told how to use each of these devices and when to use the devices and how to report information back to their medical provider. And here's another one which is perhaps more likely to be the wave of the future. This is called the HealthWatch 5, and it's a healthcare phone. And it's a single instrument which, with suitable attachments, can undertake the same range of tests, and it also measures body fats, provides specific advice on diet and exercise, and reminds patients when to take medication. So this is something you carry around with you. The key advertising slogan you can see on the left-hand side there is anytime, anywhere. And these devices also track what's happening to you over time. You see the glucose test on the top right there. So a record of your glucose tests will be maintained and can be passed on to your doctor, obviously using the mobile phone. And in recent times there have been a deluge of mobile phone apps and accessories. Here's a short list: medical scale, pedometer, blood pressure, blood glucose, heart rate, camera, microscope, stethoscope, spirometer, peak flow meter, pulse oximeter. You can also, in the US now, recently approved by the US FDA, there's an electrocardiograph, an ophthalmoscope, an otoscope for looking in your ear, and if you're really keen you can buy your own plug-in ultrasound, which costs a mere $7,500 and can be attached to your iPhone. So a lot of gadgets around. You can also use your smartphone, of course, to download lots of digital encyclopedias, medical encyclopedias, disease-specific guides, some produced by international agencies including WHO, some by national agencies such as NHS Choices in the UK, and a lot by commercial organisations. For example, I think the largest one is WebMD, again, which I'll refer to in the notes. So there's a whole lot of devices, a whole lot of information, all available through your smartphone. And in some cases not a very advanced smartphone, fairly basic smartphone, which is now available in very many countries. There's a recent paper which looked at all the health-related apps on the iPhone. I've broken that analysis down into these various categories. You see an awful lot of them are around physical activity. They jogging guides and telling you how much effort you've put in, how many calories you've burnt, and so on and so forth. A lot around healthy eating guides, telling you how many calories are in particular kinds of foods and so on. Some providing guidance on alcohol and tobacco use, and sometimes some other drugs as well. This is about Apple because Apple retain control over iPhone apps, and therefore we know how many there are and roughly what they're for. Android apps, the other main competitor, is they can be written by anybody and circulated by anybody because there's no particular control over who uses them. Google doesn't limit the apps that you can upload onto your phone. Notice, by the way, that the percentage here doesn't add up to 100 because some of these apps do more than one thing. I focused here on the personal apps, which are probably most interesting for this session. About 15% of these provide disease-specific information, remedies, medications, prescriptions. So 15% with some sort of treatment, 15% with disease and illness-specific information. And again, often an app will provide both of these, so there is an overlap here. And notice that the largest category here is, as you might expect, for alternative medicines, homeopathies, very prominent in terms of iPhone apps, so about 30%, over 30% for alternative medicine. Interestingly, nearly 17% on ways of helping you to get a regular sleeping pattern. Given the volume of these apps, and the fact that some of them do provide specific disease information, and some of them indeed provide remedies or recommendations for medications, I suppose we should be a little bit concerned about the quality of these apps. Are they helpful or at least benign? Do they follow the medical rubric of doing no harm? There is some evidence that sometimes they can be quite useful. Diabetes apps can be very comprehensive in the kind of support they give to people who are trying to manage their diabetes. So glucose tracking, medication alarm, insulin tracking, carbohydrate tracking, activity tracking, weight tracking, blood pressure tracking, a food database to assist you in selecting your diet, trend charts which can give you guidance on what's happening, and also, of course, all of these things can be fed across to your doctor. And interesting, there have been a number of studies. Diabetes is one of the major areas covered by smartphone apps. There are several papers which have looked at the value of these apps for diabetics. There is some real evidence of effectiveness in the literature. So they can be effective. The question is, what should we do about them in general? How should they be regulated? Should they be regulated? There's around, when I wrote this, which was about 6 months ago, about 100,000 iPhone and Android apps which were broadly described as health-related. Some of these are given away freely, but quite a lot are sold. And there's pressure from the commercial side for light touch regulation. The US Food and Drug Administration, it's been essentially overwhelmed by the sheer volume of apps, and it's indicated that it will only regulate those that I described before, either ones relating to particular medical devices. So does it do what it says it does, and is it going to give misleading information to people which may cause them serious problems, or those apps which provide specific treatment advice. So those it will take a look at. Even there, the sheer volume of particularly apps providing specific treatment advice is such that it's going to take a long time for the FDA to get around to looking at all of those and to regulating them, which means it's going to exclude regulation of reference materials. So if you bring out a medical encyclopedia, unless it contains specific treatment advice on particular conditions, then a lot of those reference materials are going to be in the public domain via your smartphone. Educational apps teaching people about their condition, either those targeted at patients or sometimes targeted at doctors, will not be regulated. And it perhaps more reasonably is going to leave aside tools such as magnifiers, microscopes, recorders, communication aids and so on, which may be used for health purposes, but are more generic. Serious concern that existing regulatory systems are not well suited to address the flood of new products coming onto the market. Concern from both sides, actually. There are two views on this. We're left with rafts of health-related apps that give advice that is simply incomplete or plain wrong. And from the commercial side, the mere mention of diabetes would cause the app to be regulated by the FDA. Such regulation discourages the kind of educational and motivational messages that our country needs to stem the tide of this disease. So two radically opposed opinions there. One saying you should adopt the cautionary principle that you really shouldn't let out apps which people are going to use in management of their illness, maybe which will cause them harm because they're giving information which is incomplete or plain wrong. And the other saying that this is stifling innovations which could greatly assist people with these conditions and delaying their introduction.